Hi there and welcome to this episode of Psych Attack. I'm Dr. Jasmine B. MacDonald and today I'm catching up with Ryan McGrath to explore the intersection between physiotherapy and psychology. I hope you're going well and have that cup of tea ready to go. Hey there Ryan, welcome. It's so good to have you here today.
It's nice to be here.
Your work, I think, is particularly fascinating because you draw these two disciplines together, physiotherapy and psychology. But before we kind of jump into that, a nice place to start might be for you to introduce yourself and the training that you've done.
So I'm currently doing a PhD at Cite University. I'm also a registered physiotherapist working 1 day a week at a refugee health clinic in Victoria. My training has predominantly been in physiotherapy, but I started physiotherapy in 2016, and I had always had an interest in psychology. I was tossing up between physiotherapy and psychology. And after doing my first psychology subject as a part of physiotherapy, and that's the only one you really do in the course that I did at Charles Sturt, I then went to apply for concurrent studies in psychology and physiotherapy. And they're like, no, well, you can't do that. And I'm going, oh, but there are ways. You can do it over summer. I can make it happen. And they said, no, we're not allowing that. So I went and did single subject study for my first two psychology subjects. And they were pretty much a repeat of what I did in physiotherapy, but they were, APEC, psychology accredited subjects. And then I went back and said, look, I've already started. Here are my grades. Let me in. And they finally did let me in. And then since then, I've completed 9 psychology subjects. I was planning to, almost finished an equivalent of a grad dip, and I'm hoping to do that in the next couple of years. But at the moment, my passion's in research and practice, and psychology is slowly coming along the way.
Yeah, okay, nice. I really like that you just essentially didn't take no for an answer.
No.
It's like, yes, this can work and they are complementary. I shall do this.
It was worse in my first semester of uni. I sent actually the first email going, is this possible? And now looking back, I'm going, I hadn't even finished my first semester of physio. And I'm going here and saying, let me do this thing. I've worked it out and all that type of thing. And they still went, nah. And then I went an email back again. And I just really probably annoyed them to the point they let me in. And all the way through at the start, and I find this really funny now, that I was asked, why would you want to do physiotherapy and psychology together? Like, what's the relevance and why is that important? And at that stage in my physiotherapy journey, I had a simple answer, and that was people are complex. There's mental health and physical health together. But now, since doing more research, learning a bit more about, being a physio, learning more about psychology, and learning more about the intersection between the physical health and mental health, which really we just think about as health and well-being, it's really much easier to justify. Complicated answers, but easier to justify.
Yeah, so I think that kind of evolution in your thinking and motivation is really interesting. Could we maybe talk about physiotherapy for a second? If we assume, like the listener, or assume I don't know what a physiotherapist does, could you tell me about that and kind of add how psychology assists with what a physio might do?
That is a very, very, very difficult question, and a question that I have to
You're
contend
welcome.
with. No, it's really fascinating. Because at the clinic that I'm currently working at, I'm working at a refugee health clinic, and I'm employed working as a role as a physio. But what is a role as a physio in this health clinic? It's probably easy to describe what I do and see how that, people have their own preconceptions of what physiotherapy is, and I'll explain what my practice looks like. So
Cool.
I started the refugee health clinic in November last year. And that was all during COVID, so there was lockdowns, mostly on telehealth. So when I got the job, there was a physiotherapist already working there for most of the lockdown period, and they said, yeah, it'll be telehealth. And I'm going, okay, that makes sense. It'll be video. I'll sit down in front of a screen and I'll talk to these people and we'll go from there. And that's the way I can watch people move, do gait analysis, still talk them through their story and explore all that, but I would have that visual information. I get there and no, the clients that we're working with, it wouldn't be accessible to be able to do that traditional telehealth. I actually never use video in my role. It's only over the phone because that's what works with the clients that I'm working with. And mostly they present with referrals from their GP for persistent pain. So pain that's been lasting, sometimes short term, sometimes it's new. It's only been around for a couple of months. And generally it's a couple of months by the time that I get to see them and they've tried medication and those type of things. But mostly I see a lot of clients that have had, persistent pain for 5, 10, sometimes even 20 years. So
Mm.
But already I found it very different. I was only working on over the phone, so I didn't have those typical tools that you'd think. Even that I've learned, I couldn't use gait analysis. I couldn't watch people move. I definitely couldn't touch them anyway and do all my assessments that way. And I couldn't read any body language back, and developing rapport was different. But I've found it very, very freeing and very interesting, and it's really challenged what my ideas of physio. And how that relates back to your main question is, what is physiotherapy and what does a physiotherapist do? There are over 20 areas of physiotherapy practice that people kind of work in. That's what they've argued that an undergraduate physiotherapist has to be competent in. In reality, that
Wow.
can really be boiled down to three: cardiorespiratory practice, musculoskeletal practice, and neurological practice. They're the main three that most physios work in, and most of them work in musculoskeletal. So that's the traditional one people think about. You go there, you get a sore knee, you get a sore shoulder, you go and see a physio either directly or you go through a GP or something like that. Neurophysios are the ones that people think about when somebody suffered a stroke or had some sort of neurological condition, and people think about them more working in hospitals. That's why it's not as accessible to the public. It's something, you have an injury, you have a stroke, you're sent to the hospital, and then you'll see a physio for the next, probably for the rest of your life generally, but you'll see them quite intense for the month afterwards. And in cardio nobody really understands the role of physio from the general public in that one, unless you're living with a condition like COPD, which is chronic obstructive pulmonary disease, and those type, or
Okay.
cystic fibrosis, and that's where physio is all about lungs and breathing. But there's quite a large diversity in practice, and what physios do varies greatly depending on their working and what they've learned and how they develop their own practice in it.
Yeah, absolutely. I mean, when you say there's 20 areas of like practice focus, I think in psychology we have what, seven or eight or something for endorsement, and that
Mm.
seems massive. So it's quite a diverse field.
Our skills overlap generally in those. There is common threads to it. It's again back to the tradition of physiotherapy practices. It's very, it's the Americans call it physical therapy. It's the idea that it's a physical body that we work with. So really, physiotherapy's filled every single void where you probably need somebody who has considerable knowledge of biomechanics, biology, and is probably a little like is more trained than a nurse in that role. We've specialised. We've got that more of autonomous practice. Of course, there are nurses that go out there and become things like diabetes educators or nurse practitioners, but physios, we're trained to be autonomous practitioners, and we fill every role that we kind of get sent into. So that's why you need you need somebody to help people with COPD. So we train physios up because they know a bit about lungs and breathing, and then that's a natural progression. Same thing with disability or gerontology. So working with older adults, that's restrictions of movement. So really anything that movement's to do with, but there's a lot of things that can affect movement, and I think that's probably where this conversation will go.
I'm really keen to talk to you about your research, which has worked to unpack kind of encounters between physiotherapists and clients they work with that might have suicidal thoughts and behaviors.
Hmm.
So maybe you could just provide a bit of an overview about that and like what's interesting about this topic, what drew you to it.
What I'm interested about, and I'm interested in really all those areas of practice because it's so diverse, physiotherapy practice, but the ones that I know most about and there's been more discussions about is private practice physiotherapy. That's where the majority of physios work, and it's also, in many areas, it's quite isolated. Physios generally, collate or group together in large physio practices or even by themselves. It's often not very common to see multidisciplinary physiotherapy practices. And when you do see them, they bring on things like exercise physiologists or occupational therapists, and they're kind of similar as well in terms of
Okay, so they herd in nature.
exactly. And they get bigger and bigger, and they develop kind of echo chambers amongst them, which is really cool because you have lots of different. Each physio generally practices slightly differently, but we all kind of draw on the same evidence, the same research base, and the same way of thinking. So how that relates to my work with clients with suicidal thoughts and behaviours and physio's experiences with them is that I was interested because when you're working in musculoskeletal private practice, you're dealing with people with persistent pain, and associated with often persistent pain or any type of pain is disability and impairments in function, and that by itself is quite a stressful situation, particularly when some of these injuries and some of these issues that people can have can be really, really, really stressful and have some long-term detrimental impacts, or they can be perceived as having quite long-term detrimental impacts. So, for example, lower back pain is one of the highest conditions in terms of disability and burden in the health system. So, we talk to these people, and because we're isolated in practice and we're first contact practitioners, people come in and tell you their story. And physios are meant to, particularly when they're working in pain, and all areas of practice, but particularly in pain, to complete a biopsychosocial assessment, which in other words means we look at biological factors, we look at psychological factors, and we look at social factors. Yet our training generally is skewed to knowing the biological, biomechanical factors in that equation.
Mm.
Yet we're encouraged to do all of it. And there's a couple of other approaches too that are really encouraging, physios to ask more open questions, like tell me your story. How did you get here? How's this affecting your life? Does this get you down? So when we're exploring these type of questions, we're opening up dialogue in terms of psychology and mental health. And my question was, when we're having these conversations, where does it go? And suicidal thoughts and behaviours was a very small area of research. Like, it's just great. It's quite easy to operationalize and talk to physios about. Distress is a much larger concept. So I was asking about, what happens when you're having these conversations and somebody expresses something like extreme hopelessness or helplessness, or they feel like they're a burden, those type of things. How do you cope with that? And do you ask about suicide? And then what happens when somebody discloses overt suicidal thoughts to you? How do you handle that situation, and how do you feel about it?
Mm. So who roughly did you talk to, and how did you try to answer this question?
The way that I wanted to go about it is, of course, it would be really interesting to ask clients about their perspective. But that's a very interesting group, and there's not a simple way to get access to people with suicidal thoughts who have gone and seen physios. It's not something that particularly in these type of encounters, there's not necessarily a big frequency of this event necessarily happening. A literature review that I was writing estimates probably 2 to 5 clients, per week on a lower end of an estimate would have suicidal thoughts that a physiotherapist is seeing. But it's probably more than that. But also, those 2 to 5 clients might not disclose that information to a physio, or a physio might not detect that type of information. So, for me, I was really interested in what's a physiotherapist's perspective, and how do they cope with it. So, in that way, it led it towards doing in-depth, one-on-one interviews and focus groups. Both ways are quite interesting. Focus groups allow essentially participants to go and talk about their experiences, challenge each other, and explore. And I can essentially, as a researcher, sit back and just watch the dialogue and the conversations happen. And I find that really interesting. Whereas when you do interviews, it's a lot more intimate. You can go into greater depth, but you're much larger part of the research process. So that's how I answered those research questions, by literally getting groups of physios together in one focus group, and then the other one getting a series of 4 or 5 interviews with other physios and
Mm.
talking about, what do they do? How does it feel? And just and starting from there.
I think that's really fascinating, because that method of including focus groups seems to reflect what you're saying about practice. If physios tend to practice in, not an individual person in private practice, but actually a group of physios working together, then likely the kind of practice conversations that they're having, or kind of consulting with each other about a client, then collecting data in that way makes a lot of sense, maybe even more ecologically valid than potentially for other professional groups.
What I found very, very interesting about doing focus groups, and this wasn't the intention to do this, it just was happened together when you're doing convenience. You're trying to get people who are willing to talk to me. I'm like, I'll talk to any physio with this experience, so come and find me. And then I'll essentially talk to you whenever you want to talk to me, and in a situation that's comfortable for you. So we ended up having a situation where 5 physios from a single practice all had experiences and all were willing to participate. And in that way, it made a lot of sense, and they were happy that, like, this is what they wanted to do. They said, we'll stay late after work one day and we'll get all our physios together, like the 5 that were interested. They have got more physios that didn't have experiences or weren't able to participate for other reasons, but the 5 that were interested in, they were like, let's do a focus. Essentially, I was willing to do a focus group, and so we got them all together. And so what you're getting at, Jasmine, is that this was from one practice. These people worked together side by side. And one of the
Mm.
physios was talking about how they encountered a client with suicidal thoughts and behaviours, and it was quite intense feelings of suicidal ideation. The person came in reportedly on some pain medication. They were pretty much in a crisis, were reportedly in and out of consciousness during the consult. And that physiotherapist called up another physio from their own practice, because this was one practice but multi-regional or multi-centred. And the other physio was there. So we had both physios, the one who was actually with the client and the one who actually reached out to. So I found, that type of, as you were saying, it was really, really interesting having a group that works together and then actually being able to and really let them talk between each other. So they talked about how it all felt to them and said, yeah, they called me and this is how I talked them through. And then they went back and it was much more interesting than you would have got from an in-depth interview, or you wouldn't have got the same type of information from an in-depth interview when you've only got the one physio there. And they said, I called somebody else. And then, I got both sides of the story.
Yeah, how cool to have that,
Mm.
triangulation of data and be able to bring it together. That's awesome. So you have these in-depth interviews, you have these focus groups. What kind of things were the physios telling you about their work with clients they thought might have suicidal thoughts and behaviors?
What's interesting is that while the discussion was about suicidal thoughts and behaviours, it drew on much more of how physiotherapists approach just every single patient. Because
Mm,
physios aren't going out there and saying, "Oh, I've got a client who's got mental health concerns. I'm going to focus on that," or because
right.
that's not the particularly in private practice. That's not the reason the client's presenting to you. They're presenting to you generally as a referral or self-referred for knee pain, shoulder pain, as I was saying before, back pain.
Mm,
And it just happens during a consult that these things emerge. So physios were talking about how with every single patient they want to build trust because this is a relationship they want to have with a client over a period of time. Musculoskeletal conditions aren't things that you cure. My partner studies podiatry, and she talks about how when they do ingrown toenail surgery, it's just a quick fix. She loves it because they come in with pain, they do the surgery, and then they're out, and they no longer experience their pain because they've had the surgery and they've had the solution. Whereas musculoskeletal physiotherapy is not like that. It takes time, and tissues take time to heal. Confidence takes time to build up. Strength takes time to again similarly build. So these physios want to build a trusting relationship over a period of time, and to do that, they use two types of different conversations. They use practitioner-led conversation. They use client-led conversation. So practitioner-led conversation is traditional, very biomedical type practice where people ask questions like, how's this affecting your life? Tell me about your injury. Tell me about your concerns. Tell me about how well you move, your quality of movement. And then the patient-led ones are these conversations where it's a bit more tell you a story, but also when people are doing manual therapy, so they might be doing massage or manipulations or mobilizations, that conversations just flow and people are getting to know each other. And through this context, that's where clients often express, you know, distress. Distress is the main thing that they first start presenting, and sometimes that distress is associated with suicidal thoughts and behaviours, and that's essentially how the process emerges. It's not something that's deliberate by physiotherapists. Generally, they're not going out there and actively saying, "I'm going to screen clients for suicidal thoughts and behaviours," or I'm not even going to directly ask necessarily, because that's not their role, or they don't feel that it's their role. But it's that kind of more natural process where it emerges.
So, if this is something that comes up maybe in 2 to 5 clients a week, probably more, as you said, that we haven't been able to quantify yet, and physios are saying, are not really feeling it's necessarily part of the physiotherapist's role to unpack these things, psychological distress or suicidal thoughts and behaviors. How do they manage that, or what's the reaction like?
A lot of discomfort in terms of and a lot of boundary tension. So there's not only in my research, but in also a lot of other studies that just look at physios trying to address psychological factors in physical health problems. Is that physios feel like, oh, sometimes we feel like we're being psychologists or we're feeling like we're being counsellors. We're not doing that, or we're not trying to do that. But it's this tension that physios are often reporting, and I think that harkens back to the training that physiotherapists get. It's grounded in biomedical anatomy, physiology, pharmacology, neuroscience, and it's very much on the body. And that now we're encouraged to ask, questions about what psychological factors are contributing, what social factors are contributing. So that's where the tensions come out with in terms of role boundaries, and physios, I think, are very very concerned about themselves and where they sit. Rather than saying, "Oh, I'm worried about the psychologist judging me," it's actually worried about other physios judging what I'm doing. And there's quite a lot of debates in physiotherapy practice about the changing profession, moving away from more hands-on approaches to more education and active approaches and exploring psychosocial factors. And there is that debate and tension within the profession at the moment.
Yeah, right. I'm wondering then about with their own boundaries, what kinds of clients are easier to manage or work with compared to the ones that might be more challenging.
There's an interesting study. that I found. It's published in about 2003, and I think it was in the Physiotherapy Journal. Physiotherapy Journal by a person called Margaret Potter, I believe. And they talked about what a difficult client was. So what I'll do is I'll describe what this study called a difficult client, and then I'll describe what, obviously a difficult client is somebody who's, kind of opposite this or doesn't have these type of traits. So by memory, difficult clients were people who are very frustrated. They don't necessarily listen. They feel very hopelessness. They are helpless. They don't necessarily participate in interventions, so they're not very compliant. And there's a few other types of things as well. Like often, this is a horrible term that they use, and it's a period of the research. So it's not the researchers that I'm criticising here, but it's just the period of early 2000s physiotherapy research catastrophizes. So you
Yeah.
get some, yeah, and they're hard clients to manage. The simple client is one who goes, "Oh, I've just got a niggle. It's probably going to get better. I just wanted a bit of help to get over it." And you go, "Here's your exercises," and natural healing takes over. They've got good confidence and they get back to it. But they're then, and you probably see a lot of them in musculoskeletal practice because they're people who come and see you in private practice. They've got the funds to do it. They've generally, that means they've got good a social environment. They're not struggling to pay their bills necessarily. There are definitely, we see them, but in private practice, obviously these people have the ability to pay out of pocket, and particularly when Medicare rebates aren't available for first contact consultations, you have to go to a GP to get any type of funding. These people recover quite well. But then there's the other coin, is that the ones that get labelled difficult patients are those ones who have persistent pain. They're often tried everything, or then they get perceived as not wanting to try anything. They just want a fix. They want to, like the ingrown toenail thing, they just want the musculoskeletal equivalent. And that's what they get labelled as difficult clients. But in reality, that I think reflects a lot of distress in their life, a lot of lack of self-efficacy, and those things like hopelessness, helplessness. They don't necessarily have the tools to be able to get through it, and they don't actually have the literacy because not many people understand the true nature of pain being a pain experience and not associated with tissue damage. So these are conversations that we need to try to have, but they're also something that are difficult conversations to have, and something that we're not well trained at having.
For sure. I remember like reading through your findings and reflecting on, physios saying clients that are really clearly unwell, they're really distressed. Those ones are easier to kind of work out what you're supposed to do. And the clients on the other end of the spectrum that they're kicking along fine, or they don't have that kind of clear indication of suicidal thoughts and behaviors. But it's really that space in the middle that's pretty challenging for physios.
But that's where the majority of physiotherapists lie, clients lie. They're either people who recover, they get well quickly, they don't have a lot of psychological factors we would call that are indicative for long-term disability. And then there's that middle client group. And it extends out to all the way to suicidal thoughts, but we just don't know which ones are here unless they disclose it and are really open with it. Are the people who are really struggling in life at the moment. They're languishing, they're only surviving, they've got pains dominating their life, they often can't work anymore. So once you can't work, that means you've got financial stresses, and everything is starting to accumulate and put a lot of load on their life. And they're often getting labelled difficult patients, and they mostly rely on that middle space between kind of like that middle range of distress. And when you have really high suicidal thoughts, the reason why physiotherapists are more confident or at least more comfortable in what needs to be done is because physio is less involved. They go, okay, this person is in real danger at the moment. I'm clearly not the person to help with this. Let's try to refer to another health professional. Let's try to, are we talking about calling, mental health access line or lifeline, or calling an ambulance, those type of things, or even saying you need, this is something that's obviously significantly concerning you. You're going to need to go and talk to your GP about this. So they're quite clear, but it's the group in between that they're hopeless, helpless, but they haven't necessarily gone out and said I'm having thoughts of suicide, and that's where it's very, very difficult for physios.
Like a sense of uncertainty of not really being sure. Is that what it's about?
Uncertainty and complexity in musculoskeletal practice, not just musculoskeletal, but working with people. People are complicated. There's lots of factors involved, and that they talk about I think it's in all areas of healthcare, but you have research and then you have practice, and practice is an art of applying research and the patient in front of you. And, evidence doesn't speak for itself. You have to interpret it and you have to make it contextualize, and it's an art, and that's why it's challenging. So people are complex anyway, and when you start adding these psychological factors, which are really psychological factors, are involved in everybody. They don't just appear in people who are distressed, but they become probably larger barriers or a larger contributor to people's pain and disability in a certain group, and that they require addressing. And that's when it becomes really, really difficult. And that's where people feel uncertain. So there's uncertainty in musculoskeletal and physiotherapy practice everywhere. And then that's just exacerbated in this particular domain, which is distress and suicidal thoughts.
While listening to you and talking about, where this appreciation or acceptance of the role of a physio, once a client's showing some kind of psychological distress, I'm just sitting here and I'm wondering what it's like for you to have conversations with other physios. Maybe you might meet them for the first time and you're talking about the research that you're doing. What's the general response that you tend to get? Is this like something that's becoming more and more accepted that needs to be looked into, or is it still like, nope, this is not what we do?
I need help. That's the one that I get all the time, and it's really difficult because my research hasn't focused on, like, I have ideas, and from my reading of other literature, I have some suggestions that might be able to help. But I've really just started, particularly going, what is your experiences? What are the issues you face? And then, as part of the normal research process, once you identify issues and problems, then you go, oh, okay, let's try doing this, type of training or this type of approach and see if that actually works. So I get a lot of people going, oh, please help me. And I'm going, no, I just really know what you're struggling with. And I have developed things that I find that work for me. And when I get pressed hard enough, I say, oh, well, I do this, but that's not what we need in physiotherapy practice. We need essentially more research and more time spent, and a growing body of researchers actually exploring how do we navigate this space. So I think that half answers your question.
Yeah, it absolutely does. And I guess that, we talk about in psychology that scientist practitioner model, that is quite challenging to pull off. And I guess that's benefiting you in this context because you're doing this empirical research to find what the issue is. But it sounds like you're really at the beginning of working out what to do about that, as you collect more and more data. So being able to draw on your practical experience and what you do is better than just going, don't know at all. And you're tentative, as you say, like more research needs to be done. But it's nice to have both of those to complement each other.
Exactly. And I tend to draw on, so I've got the luxury that, obviously I've only got personal experiences within one university and two courses within a university. So in some ways it helps you go, oh, look, they've got physiotherapy and psychology programs. So within a university, so I can compare and contrast. And when you talked about the practitioner scientist model of psychology, I find it interesting that even a part of, I'll talk to Charles Surtz, it has a qualitative research subject. So, and also every other subject, like psychology tends to be, on my experience, still quite quant heavy. There's a lot of interest in quant research, but there is still a recognition and support of qualitative research,
Yeah.
Critical psychology, and those type of areas. But in physiotherapy, qualitative research doesn't even get that much attention at all. It's out there. And I find it really, really interesting. That's why I probably have lent to that one, because there's a bit of a gap in the research there. But physio is about RCT. So we're not necessarily trained as being practitioner scientists, but we're trained to be evidence-based practitioners, which means we learn about what type of evidence that we draw on, and we do research subjects, but they're not embedded in each of our subjects because the degree is shorter. You're talking about really doing 4 years of psychology, and now it's going to be 5 with the changes, at least at minimum, to get provisionally registered, and then you're doing your supervision. Whereas in physio, you're 4 years and you're fully done. You're fully registered. Go out on your own. You're right. So we don't often participate in research as much. We just draw on research, and I think that's a limitation of the profession, and that's a limitation of timeframes. Yeah.
Yeah, it's really fascinating, because you're saying that the focus tends to be on RCT, so randomized controlled trials, and you've
Yep.
adopted primarily a qualitative approach. This is going to seem like an obvious question, Ryan, but why?
Because essentially you start with a research question, you go, what do you want to answer? And then you go and pick methods about that. And I have been very, very fortunate because of my exposure to quality research and my interest. I was very interested in journalism, and I see kind of qualitative research as scientific journalism. You're doing many of the same things, different purpose and different background, but I see the parallels there. You start with a research question and you see what essentially method is most useful in answering these questions, and quantitative research is still really useful. But it essentially, in some ways, provides crude analyses of large groups of people, and it has its own limitations. And I think that's the thing is, in physiotherapy, we hold RCTs, and not just physiotherapy, in medicine in general.
Yeah, in psychology as well. Yeah.
R- RCTs are the gold standard, and that you have your tiers of research, and you go down from that, and qualitative research stacks itself nicely down the bottom. And when we're drawing on doing evidence-based practice, that's where you're meant to go to, except for a lot of RCTs aren't necessarily, all the limitations are not necessarily representative of the samples that you're treating anyway. So there's a degree of, lack of context. And then there's also things like, the fact that people look at RCT and quant research and as this objective truth. And here's the answer, and here's how you should apply it. Actually, that's where the debate's a lot in physio now, is there's a lot of physios going, yeah, we live and breathe the research because we've been taught, particularly in the last 20 years, be evidence-based practitioners. So we just believe research without, particularly quant research, without really understanding it or understanding its limitations. And then there's the other group who's now interested in qualitative research, but it's a much smaller group, or at least qualitative type practices, understanding human experience. And we have to navigate, the vast majority of the research is quant. There's only a small amount of qual research, and how do we actually practice as clinicians? How do we draw on this literature base?
Yeah. All right. So you've alluded to this a couple of times, which is the broader interest that you have beyond focusing on physios who have encounters with clients with suicidal thoughts and behaviors, but actually being more broadly interested in psychological distress. Let's unpack that. Like, what does psychological distress look like, and what's your plans for future studies?
Psychological stress. What does that look like? Depends on who you ask. So
Uh-huh.
that's the
It's a
first
loaded
thing.
question.
It is. So lots of people have defined psychological stress as purely symptoms of anxiety and depression. That's the way it's operationalized. You see lots of surveys that pretty much hit those type of things, and they're pulled from diagnostic criteria. And in some ways, these diagnostic criteria look at psychological distress, but then they're also designed to give an indication that there might be a diagnosed mental condition that's underlying this. But I look at psychological stress as something much more broad and complicated. We can experience emotions in very different ways. So psychological distress could be, depression, anxiety, could be feelings of grief, rumination. The exciting way of looking at psychological distress is if you kind of ignore, DSM and diagnostic models and go, this person, what is the stress? And the other thing too, it could be anger. So the way that I kind of see distress is, it's person reported. So if somebody says that I'm not doing very well, I'm really struggling, that's an indication of distress. And then the way they experience it will be individual to them. And of course, you can go and list off and rattle off more things like helplessness and hopelessness and rumination and all those type of things that fall under psychological stress. I don't like the term suffering in this definition, but very, very simply, there's one person who decides psychological stress is a state of emotional suffering. So in some ways, that's a pretty good indication that it captures a lot of different type of things.
Yeah, and I think with your research, it's interesting because it's self-reported, but then it's from the perspective of the physiotherapist, and then you interpret and work with that.
A lot of different layers there, isn't there?
Oh, there's layers, definitely. If you can share, what kind of ideas for studies do you have next?
So as part of my PhD research, I've essentially, you could argue, some people might look and go, oh, you're just doing the same study again, or, a bit bigger, and you go, not quite. So suicidal thoughts and behaviours in the past was, when I said it was easy to operationalise and really talk to clients about, physios about, is that, we're talking about referral points. We're going, if somebody's really in distress, I don't think anybody's sitting here and saying a physio should be providing psychotherapy for somebody who's having suicidal thoughts. That's pretty clear cut. So when you're having these discussions, but psychological stress is much more complicated than that because it's a spectrum. You can have no psychological stress, you can have very minimal psychological stress, and you can have high levels of psychological stress. And there's a few texts that I've read from physiotherapists in Norwegian and some in Australia that's really, really telling. So they talk about how really anybody who's experiencing pain is likely to be experiencing, essentially psychological distress. Psychological distress and pain are intertwined. And one really interesting way of looking at it is this Norwegian text said, when somebody comes in and they're in pain, but they're not experiencing any psychological distress that you can observe, that's a concern in itself. Because when you're experiencing pain, it's a stressor. it's an unpleasant experience. It's not a good thing. That's why they've come to see you. And
Mm,
if they don't appear very distressed, then what's going on? What are they suppressing? What are they hiding? What are they, not wanting to share with you?
interesting.
So as a physio, we work with stress all the time. And then the question is, when do we get other people involved? And I love this, and maybe it exists out there, but from what my reading, it's not very common. But this idea of multidisciplinary teams, yes, they're great, but that's where I look at private practice, and we're just surrounded by lots of more physios or OTs or things like that. And you go, this whole multidisciplinary team where you can go, oh, I've got a referral, I'll just send them off to somebody. And then I'm from a regional area, so there's often months of waiting list before you can go and get that support. So
Mm.
it's really, really tricky because physios are working with people who are really distressed. And I bet you a lot of them would refer to a psychologist or a counsellor or a social worker or anything like that if they could. But also, our funding models don't allow that very simply. So that's where my interest is now looking at the practices and experiences of physiotherapists with clients experiencing psychological stress, because it's much bigger than that. And physios are involved in the management of distress in that way, particularly what people define as pain related distress, which is a complicated topic in itself.
While you were describing that, it kind of occurred to me that this might be, it might just be that avenue that some certain demographics who aren't likely to present to mental health services are going to feel a lot more comfortable going in and seeing a physiotherapist, and that the distress is going to be, something, as you've said, is intertwined with the experience of pain. But for some who would be okay seeing a GP or a health professional, it's easier to step into the door of a physiotherapist than necessarily try to get a referral for a psychologist or see a social worker. Do you think there's much in that?
There is a lot in that, particular, and again, we're talking about pain here. And a part of my research is I really want to explore other areas of physiotherapy practice, because physios work with more than people without pain. They work with people with disability and all these other areas.
Yeah.
So, and they're all stresses, but that's why it's all unique. So that I'm also interested in that. But getting back to pain, pain is something that people often describe as it's happening to them. It's not a part of them. It's happening to them. Oh, my foot hurts. It's something separate. It's like, I'm not sure if the listeners would be familiar with Lorimer Moseley, who does Explain Pain. And there's an interesting video where he describes chronic pain, and in the imagery, they've got a little dog that's biting at somebody's ankle or their shoulder or their back, and it's this external thing, so it's not a part of you. And that makes it very comfortable for people to come and see a physio because it's not a part of them, and
Mm.
it's just something new. And pain's not something that, in reality, we all experience pain, and we all experience pain quite regularly, but we don't experience necessarily problematic pain. Like, a lot of people don't necessarily experience problematic pain often. So when it does become problematic, it's something else. They want it cured and they want it fixed. So, and again, a lot of things for some pain treatments, because there's such a, we're getting a nociceptive input, which is just essentially not a pain signal, but sensory information from a joint. So when my partner does a ingrown toenail surgery, there goes that noxious stimuli. There goes that sensory information. It's solved. So people think that often back pain can get solved in the same way, or shoulder pain can get saved. That's why you have high rates of knee replacements. You go, oh, I've got knee osteoarthritis. It's painful. All I can do is go and get surgery. And we've realised that that's not the case. There's psychological factors that are intertwined in all of this.
Yeah, good points. What aspects of psychology do you think are already being applied, solidly within physiotherapy?
Ooh, solidly. I'd say bugger all being applied solidly. But this is the thing, is that I think there's a lot of well-intentioned physios, and I don't think they're doing harm. They're just trying to do the best that they can. And that's what all I'm trying to do is, when I'm in practice, is doing what I can and what I know. So they're drawing on every little bit of literature that they can. So I know that there are physios out there who have, some have gone to the extreme. There's a couple of dual registered psych physios in Australia. I'd love to talk to them. Then there's a couple that have gone off and done quite significant training. I know one that's almost finished their like a postgraduate degree in cognitive behavioural therapy, and they get asked questions like, "Oh, how are you ever going to apply that in physio?" So that's another story. And then there's others that I know that they're looking at is doing low level CBT.
Mm.
So I know that there's a New South Wales mental health group and full of physios, and they're really interested in learning about low level CBT as part of insurances and CIRA. And then there's physios who are just trying to do their own thing, practice a normal physio, but are now reading literature and saying, oh, there's things like motivational interviewing that they want to get involved in, or they want to get involved in ACT type therapies and those types, or at least not necessarily performing these therapies like ACT or CBT, but adopting those principles. And that's where I think physiotherapy approaches such as explain pain, which is a physiotherapy. It's a general pain approach, but predominantly practiced by physios, and it draws on from, I can't recall what area of psychology it draws from at the moment on top of my head, but I think it draws from like neuroscience and cognitive psychology. And then there's cognitive functional therapy, which also draws on cognitive psychology and that literature, but also draws heavily on behavioral psychology. And these are kind of physiotherapy approaches that are stealing ideas and practices from the psychology literature and trying to apply it in normal practice and make it contextual for physios, which is a challenge in itself. And they're doing great. I'm really excited to see where they're going, but it is a challenge.
Mm.
Like to invent your own therapy, essentially. It's basing on, and these physios who are doing it, they've spent 20 odd years researching psychosocial factors in low back pain, shoulder pain, plantar heel pain, but they're not trained psychologists,
Right.
and they obviously talk to psychologists and talk to people like that. But it is a challenge appropriating that when you need quite significant training in both to be able to develop some of these therapies.
Yeah, sure. Well, what about kind of reflections from your own practice? So you're saying, the work that you do with refugees. What do you think your study in psych and the things that you're learning through your research add to your kind of daily practice?
So the first thing that I find very interesting is that when I was talking about being, what is a physio, and I'm talking to people over the phone, so I'm not hands, I'm not doing anything like that. What I've been interested in, and it's been really comfortable reading literature and supporting my own practice, is that you don't have to confine to the stereotype of what a physio has to do. There's different ways of approaching it. There's lots of people, you find them, it's like Norwegian psychomotor physiotherapy. They encourage, some of them do after somebody has their exercises, that they have a nap in their consult room. I probably shouldn't say this on a recording, but I had a patient and their partner come in a couple of weeks ago, and we're doing all their, essentially low back pain, doing some lifting exercises, really actually challenging them, seeing what they can lift, and because they're very fear avoidant, didn't want to bend their back, didn't want to do anything like that. So we started off with some low weights and see if you can bend twists. And I had a heart attack when she went down and grabbed a much heavier weight than I expected, because I had a whole range of them, and I was going to go 1 through 1 to 1 to get up to 25 or 30 kilos. And she just went for the 30 after doing the first two herself and was fine. I had a mini heart attack then. But so it shows also my own beliefs about, I know the spine's not fragile or low back's fragile, but I still get scared.
Mm.
And she did all these exercises and she did really, really great. And she felt like she got a lot of confidence. But naturally, after picking up all those weights for about half an hour, she was a bit sore. So while I was seeing her husband in the gym, she just popped back and I said, "Oh, just have a relax. Here's the plinth," and turned off the light because she was just comfortable there. And obviously she's looking after her kids. I think she's got quite a number of kids and she's got all those stresses in her life. So we turned off the light. I found a random blanket in the back and let her, and she had a nap while I then did the next 45-minute consult with her husband out in the gym looking at his issues. So, and then she came back, and when we flicked on the light, we knocked and flicked on the light, and she came out and she was feeling much well rested and no longer stiff and sore, and she was ready to tackle the rest of her day. Because I'd been talking to her earlier about it's important to do more exercise, more movement, really get some confidence in your lower back. But you're also running ragged looking after all your kids. You're telling me that you're running at 110% all day. And I'm not going to say here, don't do all of that, because that's in reality. How do you reduce that significantly when you actually are a care provider?
Mm.
But what I was trying to iterate is try to run at 95%. Give yourself that little bit of time, that little bit of self-care, that little bit, don't hold yourself. If you do cooking at 6:30 at every night, if you're 15 minutes late, that's okay. Don't put yourself in this stress, this anxiety state all day where you're running ragged. Time yourself. So that was the reason why she's done all this exercise. Go and do some self-care. Just relax. Do some gentle movements in there if you want. Have a nap, whatever you want to do, and then carry on with the rest of your day. So I would have never had the confidence to do something, to let a patient literally have a nap in my consult room if I hadn't been reading these approaches from Norwegian psychomotor physiotherapy. Oh, and the other part with it, I ended up sword fighting with the. It was a very odd consult, actually. Those two, I was normally my consults are a little bit more typical physio, but these ones were a bit bizarre. But he's out there, so he's talking to me about he's had shoulder pain for a significant amount of time, and then he doesn't want, like, he doesn't find the motivation to participate in exercise, like in therapeutic type exercise. He goes to the gym, he's quite strong, quite, when I do all those things, muscle testing and everything like that, he's really, really good, but he still experiences persistent pain. And so I've given him exercises in the past, and he doesn't really do them because he doesn't feel that they're meaningful, and they've been similar to ones he's done before. I go and talk about, because there's a few physios talking about drawing on psychology, like mindfulness and meditation and those type of things. So he's done that in the past, and that's something that physios tend to do with clients when they're really in these anxiety states, or they're really worried about moving. And you've got a lot of this is actually to calm yourself down, move freely, don't really tense your core muscles and everything like that, because often when you're in pain, everything kind of jars up and you don't want to move, goes into hyperprotective mode. But he's already done that. So I'm going, what do I do? I'm running out of things here, and he's not doing the exercises. So how can we get him to do the exercises? So he's got a big family, like, of course, he's got a big family, and he loves playing with his kids. So I'm going, how do we get you actually to move and enjoy and actually do it regularly? So we ended up prescribing, we played with sticks for a while, and we were sword fighting, because as part of sword fighting, he was twisting, moving, flexing, moving with purpose and enjoying himself. So his essentially exercises for the next couple of weeks is to go home and go to Big W or Kmart and buy a styrofoam sword and go and play with his daughters and get moving and do that type of exercise. Because you don't need specific exercises for low back pain. You don't have to be doing joint specific exercises. You can do things that are meaningful and that are interesting, and they're more general, and that can really help too. So
Yeah.
yeah, went from his wife's had a nap and he's sword fighting. So I don't know what they think physiotherapy is. So
But that integrating movement and therapy into everyday life, instead of it having to be something completely separate or serious and repetitive, I think is really interesting, because it's actually tying really broadly back to psychology with the work that you do, in terms of, with her in this context, it was about confidence, and the cognition around that, and with him it's
yep.
motivation. So comes back to you saying earlier about the influence of motivational interviewing, of, well, why are you here? You're here because you want something to be different, but we all struggle with motivation. So weighing up what are the pros and cons of doing different therapies, or tricking him into therapy by playing like sword fighting with his kids, I think is fantastic.
But it was also very candid. This is the thing that I've drawn on, the psychology type literature, is that you explore, you do case formulation, so you get to know more of their story and what their strengths are, their weaknesses are, and what their goals and aspirations are. And physios are trying to do this, but when you draw on what psychology is, it's you guys have been doing that, like psychologists have been doing that for many, many years. This is not new stuff. So when, as a physio, I'm going, okay, my main mission for this consult, I don't need to do any manual therapy. I need to find a way that he can do some of these exercises, which we know will help him. But we have to find a way that, obviously, as you're saying, that he's motivated to do it and will enjoy doing it. Because the other thing is, when you have these things that you're enjoying in your life, that improves these, what they call is safety messages. Like, you can move and not have pain. And what was amazing with him, and he actually was, in this conversation saying, when I do shoulder flexion with a weight in my hand, I'm focused. I just think about my shoulder. I think about it and I can't stop thinking about it. I feel really tense. So I stop breathing. And we've tried to do relaxed breathing, and that's helped a bit, but he's still fixated on that joint. But when you get him to do something more meaningful, something more general, he doesn't think about his shoulder. So he was moving freely with no pain, or very little pain, when he's sword fighting. But when he's doing a specific exercise where he's focusing, and that's the type of distraction therapy. And what also we're doing is behavioral experiments. So we're seeing what type of things, so we put you in a different context, different environment. How do you go? How does this affect your pain?
Yeah, it builds up that self-efficacy. If you can point
Mm.
that out and go, look what you're doing. This doesn't match the schema that you have of what your shoulder's like. Yeah.
Expectation violation,
Yeah.
exactly. And that's what we try to do, is that we ask people, what things can you do, and then go, oh, there's a little bit of, and you don't tell them, it's not a lecture process. You go, you told me you don't have pain here. For example, if you have somebody who gets into a hot pool and they see, oh, they can move freely, and then somebody who says, and they don't have any pain, and then you have somebody who has pain like all the other times, like, in cold weather or when they're outside of water, you say, so there is a situation that you can experiencing, low levels of pain. That probably points to something not being structurally wrong with your back.
Mm.
We're dealing with a lot of cognitions. we're dealing with a lot of emotions involved with this in terms of the distress and the catastrophization and fear. And then we're dealing with a lot of even social factors involved. And that comes down to a lot of my clients at the Refugee Health Clinic have quite, obviously they're coming from backgrounds that have, been associated with a lot of stress, they've got a lot of disruption, and they have difficulty engaging with the healthcare system because of language barriers. So they have all that challenge as well.
Yeah, right, for sure. I think any work that endeavors to bring various disciplines together and encourage eclecticism of drawing on the strengths of different approaches, I think is only a good thing. So, yeah, just really appreciate you having a chat and sharing all your insights. If listeners want to keep in touch or see what you're working on next, what's the best way for them to do that?
The best way for anybody to get in contact with me would probably be to look up Ryan McGrath at Cite University. You'll see my research output, and that'll have an email address there. I have two. I have a staff one, which is rmcgrath@csu.edu.au, and then Gmail at ryanlachlanmcgrath@gmail.com.au. So either one of those ones is fine. I really encourage people to reach out. I love having these type of conversations. And the other thing too, which I didn't get to mention, is that I'm sitting here stealing all this psychology. I feel like I'm sitting here, I'm going reading this literature and going yoink, 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 yoink. But I think it's really important that we do the inverse, because I talk to a lot of, particularly from my understanding, a lot of psychologists aren't necessarily comfortable with working with persistent pain or chronic pain because it's not a large part of the people presenting to them. And similarly, I've spoken, like this is something I know for sure, is a lot of social workers who work with people and provide trauma counselling and those type of things. Pain's something that scares them because it could be something biomedical, it could be something scary. So I encourage people that we also, physios need to give away our knowledges of the biological and biomechanical. So it should be a bit more of a reciprocal relationship rather than going, I'll just steal what you guys do and give nothing back and become, and fill that middle space. We need more practitioners getting involved with people who have both, physical health and mental health challenges and issues that they're facing.
I think that's a really important sentiment. So I'm glad that you added that. And when you're saying that, I start to think about, from a psychological perspective, probably some of the people that we might see when they have chronic pain are also presenting with some kind of substance use. Not always, but that can be a factor as well, which further complicates things and sometimes means, a bit of a juggle of what service needs to be involved if you only focus on mental health as opposed to substances. So
exactly.
Yeah, there's a lot to factor in there, but that idea of drawing in and learning from both and not just, some reciprocal stealing sounds sounds ideal.
Exactly.
Amazing. Ryan, thanks so much for coming and having a chat. The work that you're doing is super fascinating, and I'm very confident the listeners will have enjoyed hearing your insights and the things that you're working on. So thanks a lot.
No worries. Thank you for having me.
For those of you at home, that's all for today. Show notes for the episode can be found at www.psychattack.com. If you've enjoyed listening to Psych Attack, please rate it on your favourite podcast platform and share this episode to help other people find the show. If you have questions or feedback, you can reach out on Twitter at PsychAttackCast. Thanks for listening, and we'll catch up with you again next time.